Welcome back. All right, let's just dive right into this explainer, where we decode the absolute complexities of medical decision making. If you've been following our series, you know that accurately selecting an EM code almost always hinges on that MDM level. And look, let's be real for a second. Nothing gives coders and providers more daily headaches or, audit anxiety than getting this specific part wrong. So today we're focusing entirely on element 3, the risk of complications and/or morbidity or mortality of patient management. We're going to break down exactly what this means, how you actually score it, and how to completely avoid the common pitfalls that trip up coders and providers every single day. Here's our agenda for today. Decoding patient management risk, minimal and low risk tiers, moderate risk and SDOH, high risk intensive toxicity monitoring, shared decision-making interventions, and we'll wrap up with the top audit compliance guardrails. Section 1. Decoding patient management risk. So when we talk about risk in the context of E&M coding, we're really looking at two very specific things: the probability of an event happening and the severity of the consequences if it actually does happen. As the guidelines clearly state, a low probability of death still counts as high risk purely because the outcome is so severe. Right? On the flip side, a high chance of a minor self-limited adverse effect might only be considered low risk. And when we use the term morbidity, we're specifically talking about a state of illness or functional impairment that's expected to be of substantial duration, meaning function is limited, quality of life is impaired, or there's organ damage that isn't just going to magically go away, even with treatment. Now here is the absolutely crucial takeaway. Condition risk and management risk are completely distinct. They are not the same thing. Element 3 strictly measures the risk of the management options you select, or even just consider, during the encounter. A patient might come in with a highly complex, very high-risk condition, but if the provider only recommends rest and some over-the-counter pain relievers, well, the management risk for that specific encounter is low. We are grading the decisions made by the provider, the testing, the treatments, the decision to hospitalize, not just the disease itself. Moving on to Section 2, minimal and low-risk tiers. Let's start at the very bottom rung of the ladder, the minimal risk tier. This involves a negligible risk of morbidity or mortality from the treatment or diagnostic testing. We're talking about incredibly safe routine interventions here. Advising a patient to just get some rest for a viral illness, recommending gargles for a sore throat, applying an elastic bandage to a minor sprain, or throwing a superficial dressing on a simple cut. The condition and the management plan have a very, very low chance of causing any real harm. Stepping up one rung to low risk, the treatment has a low, but, present risk of causing harm. This includes over-the-counter medications like paracetamol or antacids, minor surgeries with no identified patient or procedure risk factors, think along the lines of a simple skin tag removal, as well as physical or occupational therapy. And listen closely to this next one because it's a huge audit trap. It includes prescription refills where there is absolutely no documentation of active management. If a provider is just copy-pasting or renewing a medication without assessing the patient's current condition or adjusting the dose, it sits right here in the low-risk tier. All right, Section 3, moderate risk and SDOH. Now, looking at the APC's outline for a moderate risk, this is where a ton of your daily encounters are going to land. The biggest trigger here? Prescription drug management. This means initiating a new prescription, discontinuing an old one, modifying a dosage, or continuing a medication with documented active management and review. It also includes the decision regarding minor surgery when the patient does have identified risk factors, like doing a minor procedure on a patient who happens to have a bleeding disorder. Plus, it covers decisions regarding major elective surgery without identified risk factors, like a standard joint replacement in an otherwise perfectly healthy patient. Here's another massive trigger for moderate risk: when a patient's diagnosis or treatment is significantly limited by social determinants of health, or SDOH. These are the real-world economic and social conditions influencing a patient's health. We're talking about severe constraints like extreme poverty, homelessness, food insecurity, or illiteracy. If these external factors are directly impacting a patient's ability to access care, afford their life-saving meds, or realistically comply with a treatment plan, the management risk automatically bumps up to moderate. The provider is actively having to navigate these deeply impactful barriers just to safely manage the patient. Section 4, high-risk intensive toxicity monitoring. Now we're at the very top of the ladder. High risk encompasses interventions with a high probability of severe complications or literally even death if mismanaged. We're looking at decisions regarding elective major surgery with identified risk factors, like a cardiac patient undergoing hernia surgery. It also includes emergency major surgery, decisions to hospitalize or escalate hospital-level care, and parenteral administration of controlled substances. Crucially, it also covers the decision not to resuscitate your DNRs and decisions to de-escalate care because of a poor prognosis. But let me ask you a question that trips up coders and auditors literally all the time. Does ordering a routine HbA1c for a diabetic patient or a lipid panel for someone on a statin count as high-risk intensive monitoring? Take a second and really think about that. The answer, a massive, definitive no. You absolutely must differentiate between monitoring drug efficacy, which is lower risk, and intensive toxicity monitoring, which is high risk. Efficacy monitoring, like checking that HbA1c, just tells the provider, hey, is this drug actually working to control the disease? Intensive toxicity monitoring, on the other hand, is specifically designed to watch for life-threatening adverse effects of a highly dangerous therapeutic agent. We're talking about things like cytotoxic chemotherapy, immunosuppressants, or warfarin, where providers have to order frequent, regular labs strictly to ensure the medication isn't causing severe morbidity or death. Okay, Section 5, Shared Decision-Making Interventions. This is a really fascinating nuance. AMA guidelines actually allow providers to credit the risk of an intervention even if it doesn't happen. Let's say a provider evaluates a patient and says, you need emergency hospitalization or major surgery right now. They have a thorough shared decision-making discussion, outline all the risks, and the patient ultimately declines it. Well, the provider can still count that as a high-risk management decision. The risk criteria apply to the decisions made or considered at the encounter. Actually, it reflects the complex clinical judgment the provider had to use, regardless of what the patient finally chose. It's the thought process and the medical expertise that gets the credit here. Finally, Section 6, Top Audit Compliance Guardrails. Let's put on our auditor hats for a second. Here are your top 3 compliance triggers. Number 1, always document active medication management. Just listing a patient's current meds is not enough. You have to explicitly state if you're refilling, adjusting, or reviewing them for side effects to hit that moderate risk. Number 2, never confuse efficacy with toxicity. Remember, checking to see if a drug works is completely different than monitoring to ensure it isn't causing organ failure. And number 3, explicitly document the clinical impact of any social determinants of health Z-code you use. I want to expand on that last point real quick because it is an absolute trap. Simply slapping an SDOH ICD-10 code, like Z59.0 for homelessness, onto the chart is not enough to magically trigger moderate risk. To get credit, the documentation must explicitly state exactly how that specific social factor is limiting the patient's ability to comply with the plan or access care. You have to tell the story of why the provider's management plan was complicated by this barrier. No story, no moderate risk. It's that simple. So I'll leave you with this final provocative thought to review in your own charts. Are your documentation habits accurately reflecting the true complexity of your clinical judgment, or are you leaving risk and, frankly, revenue completely uncounted because of a few missing details? What other hidden risks are just lurking in your everyday documentation? Take these guardrails back to your practice to ensure your medical decision-making is rock solid every single time. Thank you so much for joining me for this explainer. Don't forget to like, share, and subscribe to Decode Healthcare with Harsh Shah,